Thank you very much. My name's Paul Harrison. I'm the Medical Director of Dudley Group NHS Foundation Trust, and I do still see some patients from time to time. For those of you who don't know where the Black Country is, if you know where Birmingham is, it's just to the left. If you don't know where Birmingham is, I haven't in 7 minutes got time to help you at the moment, so we'll just move on. So, the Black Country is probably not the industrial powerhouse that it was in the past, but it's still got a strong reputation for ingenuity, innovation, and certainly has a very strong identity. And that's something I found out was very important when I moved to the Black Country, because if you fail to distinguish correctly between a Black Country accent and a Birmingham accent, you make enemies very, very quickly. I found out the hard way. The Black Country Alliance is a new model of acute care collaboration with three simple objectives. The first objective is to improve the healthcare for our million or so patients that we serve. Our second objective is to improve the healthcare experience for our patients, and we think also importantly, improve the healthcare experience for those giving the healthcare, especially our staff. And the third objective is to make use of our resources the most effectively and efficiently way that we possibly can. So by collaborating, we think we're already demonstrating that we can deliver win-win-win solutions. Our patients win because they can still get high-quality care delivered locally, and in some cases we're going to be able to deliver care locally that in the past has been delivered further afield. It's a win for our staff because they get to use their specialist training and subspecialty skills, which increases their job satisfaction. And it's a win for the health economy because we can be more efficient using our combined resources. We've been collaborating for some time in some areas, so we have experience in vascular surgery, ophthalmology, dermatology, and plastics, as an example. By collaborating, we do believe we can move ourselves forward very quickly. Underpinning all our work is the principle providing patients with high quality, safe care in a way that they can access it very easily. Now, in common with most people in the room, we're facing a number of serious challenges. You can all think of them, but 7-day services, nurse recruitment, maintaining specialist on-call rotations, you can all add to that list very easily. The risk for us is that on our own, we will not be able to develop and continue to provide local high-quality services that we know our patients want, and more importantly, I think our patients deserve. Many of the challenges we face are not unique to the Black Country, and that's why we're sure that the results and the products that we're getting out of our work could be transferred across the wider NHS. Toby.
Thanks for that. I'm Toby Lewis. I work in Sandwell and West Birmingham as the Chief Executive. As a Black Country Alliance, we share a common purpose. We all already provide community and acute hospital services. We share existing primary care vanguard status in two parts of the patch, and we work in collaboration with local authorities who are looking to come together as something catchily titled the West Midlands Combined Authority. So we already have a network of collaboration across the patch that we serve. Learning from other parts of the country, including the North West, we believe that bringing the Black Country together will help us to bring Birmingham and the Black Country together. In other words, you've got to organise that bit that Paul described as to the left if you're going to make things work across the West Midlands. So by applying that scale, we will become a partner not just for the local authorities, but for other parts of our system in working together. We've been at this for a year, and the key thing we've worked out how to do is what we will do when we disagree. So it's easy to stand on a platform and talk about the things you will do together, but what happens when you have a competing interest or you slightly fall out? And that's what we've been working through and have got some of the governance systems in place already to deliver. The strength of our bid is not how much we'll turn upside down or how much will change, but the fact that we will go progressively through a lean process of looking in depth at 3, 4, 5 services each year. And in that process, we will find an audience of our staff and local residents who want us to go further faster, because we'll build a strength in the collaboration for a small number of services and then apply it across the patch. Not try and turn healthcare upside down in the West Midlands and then look back in retrospect and find it hasn't quite delivered what we promised local people. In the vanguard, we want to get that going further faster. We want to make sense of how we'll work constructively with our local population, who currently, if we talk to them, would tell us they don't want us to move things and would want to have that engagement. We need to find across our 45,000 members and the 1 million patients that we serve the right model of collaboration and engagement that describes the problem we're trying to solve and sets out how we'll go about doing it. So out of the vanguard, we want to join this community of collaboration, but we want to create a community of collaboration with our local population. We want to keep it real. Darren's from Walsall. That's what they do in Walsall, so he's going to do this now.
Hi, my name is Darren Fragley. I'm the Director of Strategy at Walsall, and I am the one with a Black Country accent. So the Black Country Alliance is our acute care collaboration. We're building a powerhouse of clinical provision, and our aim is to deliver, firstly, together through a jointly owned body, or by one of us on behalf of the others, or as all three, and then together sharing the best practice. We've already had some early success. We've managed to attract some really high candidates for urology posts, which we wouldn't have been able to do as single trusts. And off the back of that, you know, the provision for the Black Country Alliance is much stronger. Our ambition, or one of our ambitions, is to have a Black Country Urology Institute by 2017, so being a centre of excellence. And it's something that's not possible on our own. It's currently not possible. We want to develop minimally invasive surgery through Da Vinci techniques and shared subspecialisations that are delivered locally. Paula.
Okay. So my name is Paula Clark. I'm the Chief Exec of Dudley Group. And I'm the only thing now standing between you and lunch, so I will make this quick. Without underestimating the work we've got to do, we do believe that through the Black Country Alliance we can truly reimagine and deliver at pace a fundamentally different form of acute care collaboration. We believe that what we're doing is something that's repeatable and it will be adaptable to other local situations. Our alliance is one which puts patients ahead of organisational form. It's one where the trusting relationships that we've developed mean that actually we don't need complex SLAs and convoluted contracts because we have trust and shared benefit. We also want to, as Darren said, become a powerhouse of care provision, and we can do that with our 1 million patients. We also want to use the Alliance to build genuine 7-day services which are delivered sustainably together and where we can learn from one another and improve standardisation and raise the quality of what we do. And finally, we want to have great clinical services for our patients, but also, very importantly, rewarding careers for our colleagues. So we hope that what we've given you so far is a sense of what we're proposing, our passion and commitment, and the characteristics that we hope will make you want to vote for the Black Country Alliance.
Thank you very much. Questions for the Black Country Alliance? There's one over there, please. Thank you.
Good afternoon. My name is Trevor Clark, patients rep for NHS England from Nottingham. Like you say, you are you're not on your own, and you get as much advice from the local communities. Can you give me an example on how you can say that the patients have a voice in your collaboration, in your quest, basically?
I mean, we're a foundation trust in Dudley, and the other two NHS trusts have also got memberships. We have really strong engagement from the memberships we've got. We've got 45,000 people involved in that, and through their involvement, the very active patient groups we've got, we will continue to involve our patients in developing the services that we're offering through the Alliance. Do you want to add to that, Toby?
Yeah, I think it's been a consistent theme of this morning, hasn't it? And I guess one of the challenges, I talked to a large group of patients last week about the Black Country Alliance, and part of their point was, what's it for and what are you going to do? And we needed to get past quite a defensive conversation about how services might be reconfigured. And I think when we set ourselves up a year ago, we've said that we'll take till this coming April to make sense of how we would hold our meetings in public, what information would be routinely publicly available, and how we would create patient governors and patient governance to challenge the professionals within the overall public board. But our central commitment to the local population and to local stakeholders is we'll do our business in public. And that's important to us, as well as building on the 45,000 members that have been mentioned already.
Thank you. A question from the gentleman over there, please.
Hi, my name's Steve Sharples. I run a PPG in the Black Country. Can I just go on from your choice of saying 45,000 members? There are over 1 million people who live in the Black Country, well over 1 million people. How are you going to hit them all?
Well, I think we've largely covered that. It's around making sure that we are visible and accessible to patients. And we'll be working with the patient groups, we'll be working with the CCGs. We have the backing of our CCGs in terms of what we're doing. They're not here today, but they are backing us in terms of the Black Country Alliance. So it's very hard to engage with 1 million people, but we're going to give it our best shot.
But we see nothing.
Perhaps if I can add to that, I mean, I think you need to take a multimodal, for the risk of using management speak, approach to this. So one solution isn't going to cover off 1 million people. We've got 1 in 20 people thereabouts who are members already. Going forward, we want to use apps. So we've just developed a recent app in Dudley so that people can give instant feedback as to what's happened to their experience of coming into secondary care, for example. We need to use social media. We need to get out there and visit practices. So I go out and visit practices and talk to the patient panels in practices. We need to do more of that, and we need to upscale it. I think that's something that we can do, but it's not something we're going to have done tomorrow.
Thank you. We've got 2 questions over this side of the room.
Gordon Cairns again. I'm also a patient rep on a clinical reference group for specialist urology. And you mentioned the Da Vinci robot. Have you got the amount of people that the clinical reference group is saying that you need to have a robotic assisted surgery in your hospitals?
The short answer to your question is yes. The longer answer is this. If you take the institutions that are represented on the stage today, and we'd love other institutions in the Black Country, Mental Health and others to join us in due course, what you'll find is that those institutions together are the size of a university urology department or a university rheumatology department. If we're going to meet the kind of recruitment challenges of staff that many organisations in this room face, we need to make sense of that maths. And what that means is we need to allow people the opportunity to practice their careers locally, but also offer them the opportunity to develop their research, education and specialist skills. Now, currently, the NHS offer is do a bit of work in Dudley and then go up the road to the University Teaching Hospital. We cannot sustain an employment model with respect to the presentations we've heard that operate on that basis. So what we want to do with 1 million people in the Black Country, and possibly more, as you say, sir, is to build on the maths we've already got and make sense of it. And that doesn't mean moving services around. It means meaning that whichever one of the services represented on this stage today you hit as a patient or you refer to as a GP, there are common standards. Firstly, for urology, rheumatology, histopathology, which are our year 1 promises, and then for the services suggested by patients and staff in year 2. So this is very much a do one in 1 year, build out in year 2 proposition.
We've got a question, I think, waiting over here.
Hi, I'm Jane Rowland from the Royal United Hospitals in Bath. I note your ambitions around transparency in terms of patient governance, but I've also heard as well that you want to operate outside a normal SLA and contractual structure. So I'd just like to understand what you've done to develop that integrated governance approach and how have you agreed that with your commissioners?
Do you want to answer that one? About the body? The governing body that we're...
Okay, that seems to come back my way. I'm sure I'll try to pass it that way, but I think the answer to your question is that we're going to need to go on a case-by-case basis. You can't approach merger, monopoly legislation, etc., or for that matter, public transparency, by saying one size will fit everything that we do. So where we're developing propositions together, as Darren said, we may be running them through the Black Country Alliance, or one institution may be running them on behalf of others. One of the things we want out of this Vanguard, as we've begun to get out of the Dudley Vanguard and the Vitality Vanguard, it is the ability to work over the longer term and make sense of some of the legislation around procurement. So we haven't got a settled position. What we do have is a sense that the status quo, in which we all go out and tender, spend an enormous amount of money, etc., doesn't really work very well. So we're trying to do a little bit better than that low bar, I guess.
I mean, one of the things that we have found as DGHs, with visiting clinicians under SLAs, we've often found, and I'm sure many of the DGHs around the room will have found this too, that you tend to be at the end of the line in terms of the service that you're given under that SLA from another organisation serving you, very often the bigger tertiary centres. So by working together, we can work without those kind of SLAs, developing the services internal to the Black Country Alliance. And that means that we think we'll be stronger together rather than reliant on trusts outside our patch to help to serve us.
We are out of
Sorry,
time.
we're out of time. So
Very
I can't
clear.
have, it was going to be the best point we made, but that's fine.
Go very quickly.
Well, no, it wasn't actually. I think the point we wanted to make is we really wanted to get across the sense that we're trying to deal with problems of subspecialist care. And some of these things never hit tenders. They're never part of the public discourse about what we should do, but they're the reason that we actually struggle to employ or retain or motivate the staff in our organisations. And if we deal with those unacknowledged problems, then I think we feel we'll make progress in the Black Country.
Thank you very much. That's the Black Country Alliance.